The Limi Children Hospital is a multi-specialty children hospital with advanced specialty in neonatology, pediatric cardiology, neurology, hematology, nephrology, and vaccination. We provide a variety of clinicians to help deliver the best possible care. Our physicians and nurses have been recognized by a number of independent organizations for overall excellence. We offer consulting services, regular nursery care, premature birth care, and treatment of babies with mild to severe illnesses across our different integrated facilities. Our neonatal intensive care units are well equipped with infant warmers, incubators, phototherapy, monitors, ventilators, and oxygen hood or nasal cannula. As a baby's and family's first pediatric caregiver, our neonatologists often begin their work by providing prenatal consultation to women experiencing preterm labor, carrying multiple babies, or following the finding of a possible congenital malformation that may require special preparation for the birth and coordination of treatment services for the infant. For more information, log on to www.limichildren.org.
Good afternoon, my teachers and colleagues. I want to start by profusely apologizing for starting a bit behind schedule. We had some technical issues, but we're good to go. And I'm Dr. Nwala Gabriel, consultant pediatrician with Limi Children Hospital. It's me to take on this presentation this afternoon. Is
Dr. Aliyu Faiza.
So just sit back and join us as we take us through the presentation. So the presentation is coming to you from Limi Children's Hospital, one of the three expressions of Limi Hospital Group. So we are go to the other side. So we handle a spectrum of pediatric cases from neonatology to general pediatrics, neurology, cardiology, and the different subspecialties in pediatrics. So for the sake of our time, when you get the slides, you can go through the other aspects of the prelude. So today we'll be discussing acute bacterial meningitis. What are the diagnostic approaches, the contemporary diagnostic approaches, and how can we overcome the challenges of management when we have cases of bacterial meningitis present to us?
So during the course of our presentation, we'll be using the following outline. So first, we'll have a case patient introduction, epidemiology, the clinical features seen in acute bacterial meningitis, diagnostic approaches, our challenges of management, complications, prognosis, and conclusion.
So we start off with the case presentation. Okay, so we managed a 13-year-old female adolescent that presented with fever, headaches, photophobia, and vomiting. So the child had traveled from Cote d'Ivoire through a number of stoppages before coming into Abuja, and had a history of contact with another child with similar illness. The physical findings revealed an acutely ill child with high-grade spike of temperature of 40, and the other positive findings on examination were hyperemic pharynx, neck stiffness, and positive Koenig and Lasky signs. The plantar response was extensor and withdrawal. So some of the preliminary investigations that we did included a full blood count which showed marked leukocytosis of 23,000 with absolute neutrophilia, and the serum electrolyte and creatinine also showed some derangement in the electrolytes, and blood culture yielded strep species. So, as is the custom of our webinar series, at this point I want to ask the audience what they think is the likely diagnosis. Then the second question would be 4 principles of management. If a child like this had presented to you, what are the 4 key things that you want to do to ensure that the case management is optimal? So we'll be expecting your responses. You can drop your comments in the Q&A section, in the chat.
Yes.
The Q&A section. Just check. Chat. Check the chat. Okay. So just drop your comments in the chat box. Let's see whether entry yet.
No, not yet.
I think we have. Okay, so
That's one answer.
share comments. Let's it can be at least this one. Let's just stick to one. Is it active bacterial or viral? Are you giving us differential diagnosis? So, what of the second? Nobody has attempted the differential, the active bacterial meningitis, passive. Good. Principles of management, no entry yet. Okay, so let's just keep the comments rolling in while we continue the presentation. Okay.
As a form of introduction, bacterial meningitis in general is when there is inflammation of the leptomeninges, which is the biomatter and the arachnoid matter. So even though there has been increased, obviously, index of suspicion for children that present with some disease, some symptoms that point to meningitis, is still a concern for healthcare and caregivers all over the country. So its importance in health-seeking behavior, early diagnosis, and for important diagnosis and treatment of meningitis. So recent reports have still suggested that we have an increased burden in meningitis, especially in areas where we have the risk factors for meningitis, the summer changes, and meningitic load. So it's important for us to actually have this diagnostic that we're going to talk about to help us in tackling these challenges in treatment and management of acute bacterial meningitis.
And the reason why we need to be very, very intentional about heightening our index of suspicion is because of the morbidity and mortality that comes with it. Now, you don't want to see a child that has been developing normally suddenly coming down with some neurological sequelae like cerebral palsy, motor deficit, hearing, or visual impairments. Okay, I think we have more
Yes, we have more
comments. So,
answers.
okay, Acute meningitis, Idris, Fatima Idris, principles of management,
Investigations,
lumbar
longer
puncture.
function, when features of risk for SCP are
Yes,
developed.
okay, so this is still part of you make the diagnosis. Once you've made the diagnosis, what are the
As
things
you
that
now
you now want to do
to manage.
to manage? Okay, so let's keep the
Thank you.
comments coming while we continue. Okay, so by way of epidemiology, this slide might interest our audience. Even in developed countries, the incidence of meningitis is not low. In the United States, you can see that the annual cases of meningitis there is more than 4,000, with 500 of these cases dying per year. The case incidence has been documented to be 1.33 per 100,000 population in the United States. Now in Europe, the incidence is even higher, so 6 per 100,000 population. So if these developed countries can have such incidents of meningitis, small wonder then why the developing countries like ours will have very high case incidence of 38 per 100,000 children. This was documented by Vasudeva in 2022. So we are not giving you figures of 2 or 3 decades back. This is as recent as last year. So in our series that will soon publish is about being published. The manuscript is ready. The isolates of cases of suspected cerebrospinal meningitis, was as high as 70.5%. Among postnatal children. So this should tell us the burden of this topical issue that we are discussing this afternoon, for us to heighten our suspicion and apply all the measures necessary to morbidity and mortality.
I think we have more answers.
Go down. Okay.
This one is
Resuscitate, antibiotics, okay. Supportive care, beautiful. So
another one, monitoring.
monitoring, very important. ABCL resuscitation, antibiotics, steroids, beautiful. Likely diagnosed acute bacterial meningitis, okay.
Travel history.
Okay, principles of management, intracranial perfusion monitoring. Okay, that can be one of the complications.
Yes.
It's not like you leave the case management and start looking for complications. Okay, vitals. Okay,
Seizures
that's
of
talking
the-
about monitoring seizures of
Yes,
okay,
antibiotics.
antibiotics. Now this child in question didn't have a seizure, so I was thinking the
The most
principles
specific
should have been tailored to the index, but I think some may present with seizures. So for those that present with seizures, seizure control will be one of the principles. The lumbar puncture, okay, that's to make the diagnosis. Okay, principles entails rational use of antibiotics in travel. Okay, so non rational use now, because meningococcal within 24 So we empirical organisms, common organisms, the first some literature presentation, but I have presentation, the child should be started on empirical concomitant steroids. So to try the entry by Idris. Embassy, steroids, particularly. What we are discussing is not rocket science. It's something that all of us are able to relate with. So let's move on.
Okay. So the common clinical features seen in bacterial meningitis is the triad of fever, altered consciousness, neck stiffness. But in majority of cases, patients will have fever, neck stiffness, and altered consciousness with some of the meningeal signs, but which is either Kernick sign, Boltinski sign, or Lessing sign. Now, these signs may not be present in younger children. Children usually less than 2 years, we don't expect to find any of these signs. So there should be a high index of suspicion in any child that presents with altered level of consciousness, high pitch cry, irritability, lethargy, poor sucking, and the child is just there's vomiting. So we should have an index of suspicion, not just that there are no meningeal signs of meningitis has been ruled out. So this is important because, like we've mentioned before, it's very important to start treatment immediately because some cases are fatal. There have been cases where within the first 24 hours, you might have shock, DIC, purpura, and death within the first 24 hours. So, so index of suspicion should always be set high for any child that is presenting any of these features.
So most cases of meningitis may not present with the index now didn't present with the classical fever, headache. Okay, there was headache, there was fever, there was neck stiffness. So some series actually say that this triad is what you find in cases of meningitis. Having said that, it can still present with a spectrum of prodromes from what Dr. Faiza has just told us, from irritability. A child that is crying uncontrollably might be a pointer to meningitis. A child that has altered sensorium might be a pointer. A child that comes in unconscious, meningitis should be part of your differential diagnosis until you do the diagnostic test to either rule out or confirm the presence or otherwise of meningitis.
So also when the patient presents, it's important to ask as part of the history, any history of travel, like our index case now that we said came from Cote d'Ivoire and there were some transit areas. Very important. Has the child traveled to any areas where we have like the meningitic belts, any previous history, any contact with anybody with any similar illness, like I also index case had a contact with a child that had a similar illness. Also, there are some not bacterial now, so like in some viral meningitis, some weather changes, like in summer, we have enterovirus, which can cause a viral meningitis. So that's also important. It might not be good, so these are also important aspects to the child's history.
Okay, so it's good for us to understand why we seek for some of this information in the course of the clerkship. Now, a child that had an upper respiratory tract infection that is poorly treated can progress. The pathogens may actually progress from there to the bloodstream and be carried all the way to the brain. A child that has any lesion like a carbuncle around the dangerous triangle of the face can have a direct spread because of the connection between through the cribriform plate to the brain. So such can still be a pointer that we might be dealing with meningitis. Now, a child that had an acute illness that was poorly treated, like this index presented, had been to 5 facilities, probably stay for some time, maybe 1 2 days, fever subsides, and off she went and all that. So if any acute illness is poorly managed, the child might actually, a child with meningitis, acute bacterial meningitis, can progress to subacute or chronic meningitis, which may not have the classical features that we've outlined. So it's good for you to have all those information. There are conditions, existing conditions like some lesions on the skin, like a child that has a spinal bifida, for instance, or an encephalocele that has ruptured. You know that all those lesions can actually form a channel through which these pathogens can enter the brain and cause the infections. So to look for some volunteer this information until you seek them from be intentional while taking history patients that present to us. Meningitis at the back of our mind.
What we have here, these areas that are so you see we have Ghana, we have Chad, Sudan. So we're talking about like this index case now. There might have been transit to any of these areas which are in the minute, so we don't even know where she got it from, who she was in contact with.
So even the Cote d'Ivoire in question, the meningitic belt, see this line that has those dotted black lines, that's the meningitic belt, causes Nigeria. Even Cote d'Ivoire, yes. Cote d'Ivoire is within the meningitic belt. So a child from any of these areas is at risk of. So one of the people that commented, rightfully noted that it could be meningococcal meningitis that the child had. So this, although they isolate, the culture isolates, said otherwise, but at least once that index of suspicion is there, you take the necessary precautions. Once you're able to confirm that it's meningococcal infection, you need to also treat the household contacts, because meningococcal meningitis, is the cause of epidemic meningitis that can cause spread and a lot of morbidity and mortality. So that's
so in Nigeria, most commonly in the north, that's where we see most of meningitis. So these are the
even some
areas.
places you can look at some places in south, even southeast.
Mostly.
But at this point now, sorry, Dr. Faiza. Now you know how we travel. You can see somebody now as we are here, doing and making this presentation. We just greet. The next second, she goes to the airport, and she can fly to any of these places that don't even have, cases of this thing. So a lot of people will come into Abuja from Sokoto and Kebbi and all that. And if they had come in contact with anybody with meningitis, nothing stops them from also importing these pathogens to Abuja. So, in as much as these are the areas where there has been reported cases, how about states that don't even report? How about states that have been managing meningitis without reaching out to the WHO to tell them that there are cases of meningitis in their locality? So you can see how close we are to this infection. And this child are free from Cote d'Ivoire. Abuja is free from this now, but The child came in, stayed, interacted with household contacts, even came to the facility.
Yes.
So nothing stops the child from also dropping
Yes.
some of the pathogens along as she, passed through.
This is still the same. This is cases of death
In 2017.
2017 of meningitis. So, physical findings in meningitis. So, the site of decolonization is also important. Also, like when the pathogen is in the nose, in the nasopharynx, you can actually find something here or on the skin, respiratory tract, GIT. So, part of other physical findings, like in our index case, I said there was pharyngeal hyperemia, which is what we're talking about decolonization. But for a neonate, you can find bulging anterior fontanelle. There might be high pitch cry irritability. Then there might also be xanthimas, which is
this meningococcal rash.
rash.
So when you find somebody with some of these ecchymotic lesions, petechiae and all that, just know that you might be dealing with a case of meningitis. These healthcare providers are not spared, just as anybody in the community can pick it. While you're taking care of this child and you don't apply your you don't wear your personal protective equipment, you can pick it up. Then there is something in the physical signs,
Also,
the paradoxical irritability. Normally, if a child is crying and you carry the child, you expect that the child should stop crying. Now, in a situation whereby a child is calm while by himself or by herself, and when you cry, you carry the child now starts crying. That's paradoxical irritability. So when you find that kind of thing, see a child that is crying, okay, some other person can put it as a unconsolable cry. You carry a child, you expect that once the caregiver carries the child should keep quiet or stop crying. If that is not the case, just know that that's one of the pointers that you might be dealing with a case of acute bacterial. Why these things are important is because in younger children, because of myelination that has not been completed, the meningeal signs may not be there. So those are the things that will help you, heighten your suspicion so that you do a lumbar puncture and know whether you are dealing with a case of meningitis or not.
So additionally, you may also find signs of actual complications.
Yes.
So like raised ICP, you might find a child with decorticate or decerebrate positioning, anisocoria, ptosis, hypertension, bradycardia. Child may even be apneic. So all these
those hypertension, bradycardia is what we call Cushing's reflex. So you expect that if there is hypertension, there should be, if all those catecholamines are at work and this one is raised, you expect that the heart rate should also be high. So if the blood pressure is high and the heart rate is now low, that's my point to raised ICP. Other things are like cross eye, there's unequal pupils. So absent nerve is the one that takes the longest course in the brain. So if the child has a brain FC palsy, it might tell you that something is going on. You check the pupils and the pupils are unequal. One side is smaller than the other side. It might point to raise ICP. Vomiting is part of it. Irregular respiration is part of it. So that's what we call Cushing's triad now. Cushing reflex can just be the hypertension bradycardia. But when there is irregular respiratory rate, that can also point to raised ICP. So for younger children, that the anterior frontal and state patterns, the anterior frontal might be bulging pens. To the transfrontal ultrasound can help you know what is happening there. Okay, we'll talk about that.
So this is cardiac sign. So once you raise the leg at 90 degrees, at the hip, there's flexion at 90 degrees, and then you try to extend at the knee. There will be pain, but not around the leg. So you ask if the child is able to, so you can ask them where the pain is. They should be able to tell you.
You expect that the pain should be at the back, or the child will try to
push you like
this other leg, you see the other leg going up to relieve the pain. Now, this test is also known as kissing the knee sign. It's as if you're moving the knee towards the child's mouth, but the thigh is at right angle to the trunk, and the leg is actually 90 degrees to the thigh. So you now try to extend the leg as if you're trying to now use the leg to form 90 degrees with the trunk. So once that is done and the child feels pain at the back, while you're doing it, you look at the examiner. I'm not seeing the examiner's face, so you should be looking at the child's face. The child may not, should do what you're expecting, you may not see it other than some grimacing of the child's face. So that tells you if the child is in pain or not. And you can actually ask the child where the pain is. The pain should be at the back, not the calf or the posterior aspect of the thigh. So where the meninges are, it's actually the back and the brain.
So Brzezinski sign. So while the child is lying supine, you do passive flexion of the neck. So what will happen is the child will try to
move
flex the knee up in response to the pain.
And the pain here is also at the back.
So another sign that we don't have the picture here is the lesson sign. So while also the child is lying, sign.
So Leslie sign. Okay, how you do the Leslie? We are used to neck stiffness, Koenig sign, and Brzezinski sign. So there are other signs of meningeal irritation, like the Leslie sign. Now, the Leslie sign, you're raising the leg while the child is lying supine like this. You raise the leg straight. That's from the whole lower limb. You raise it up, straight up. So as you're raising it up, the child feels pain. You can do it on both sides. You can do it together. You can do it one leg at a time. So once there is pain, that's another way to demonstrate that there is signs of meningitis. There are other things that you can find in meningitis, which are non-meningeal signs. They are upper tract signs. Things like Babinski reflex, plantar response, things like tone, there's hypertonia, brisk, deep tendon reflexes. Those are not signs of meningeal irritation. Those are upper tract signs. So those might show that something is going on in the brain. So whatever that is happening is actually coming from up there. A child with cerebritis, ventriculitis, and other things up there, edema, cerebral edema, and the rest may have those signs, but that doesn't mean that those signs are meningeal signs. Okay, so we'll come to the meat of the presentation.
Yes. So part of for our diagnosis, so we've already talked about the clinical features history. So we have some general investigations and specific, like index case now, when she presented with some full blood count, electrolyte urea. You can also do random blood sugar. Procalcitonin will actually also tell you there is a bacterial infection ongoing.
So it's an inflammatory, once there is inflammation, that will be raised, but it doesn't tell you is meningitis or osteomyelitis or sepsis or some other inflammatory condition. But that can be a guide for you to know whether where you are dealing with an effective process.
So blood culture can actually help you to isolate.
So blood culture, the yield of blood culture is higher than the yield of CSF culture. So blood culture, like in this index, even though we're not able to do the CSF analysis because of maternal concerns, we will come to that. It's one of the management challenges. When you don't get consent to do lumbar puncture, what will you do? You wouldn't say because you didn't do lumbar puncture, that means you can't make the diagnosis. So blood culture can, isolate the germ 30 to 50% of cases. Unlike CSF analysis, that will just give you positive culture 10 to 30%. So that it's important. That's why we had to put it in specific, because it's one way of isolating the organism. The other things, for when you're sending for CS, don't just fill a form for CSF analysis. There are things you should be looking out for. You need the cell count. What is the normal cell count? So that when you now find a result that the cell count is higher than what is normal, you know that you're dealing with CSF phagocytosis, which is one of the features of meningitis. Now, CSF glucose, you're not just doing CSF glucose in isolation, you're comparing it with the random blood sugar as at the time you collected the sample. So you expect the CSF glucose to be up to 50 to 75% of the random blood glucose.
Yes.
So if it's less than 50% of the random blood sugar at the time, then it's what we call hypoglycemia, which is another pointer or a strong suggestive parameter of acute bacterial meningitis. Now, CSF protein, you know that CSF protein shouldn't be more than 45. So by the time the CSF protein is high, in acute bacterial meningitis can be as high as more than 200. Meningitis can be as high as more than 5. Once the CSF protein is high than 50% of the blood glucose, you know that you're dealing with acute chloride. When it's higher than 110, most likely it's acute bacterial meningitis. That the culture is negative doesn't mean that it's fastidious. Fastidious means within a very short time. So if you immediately, you may not be able to get these challenges. Timing, when you collect the sample, sometimes it takes more than 24 hours before you get the result. That's why newer diagnostic modalities like PCR, is gradually taking over. So PCR can be single, can be multiplex. Single in the sense that you're just testing for a particular organism. It can be multiplex in the sense that you're doing for so many possible pathogens at the same time. So the same CSF sample, you drop it on the test kit. If it's any of the possible pathogens can be positive, and within few minutes of doing the test, you know what is responsible for the meningitis and treat. Then the current thing now that is making the wave now is what we call syndromic testing. Syndromic testing is like a multiplex PCR, where you get a single CSF. And most of the cases of meningitis that we do CSF and say CSF is clear, you'll be surprised that when you test those samples against some fungal pathogens, it's positive. Some against protozoan organism is positive. Some against some viral like herpes simplex type 2, to be positive. So the syndromic testing tries to check for other possible causes of other pathogenic causes of meningitis. So that's where the world is going. But I must say here that these new things have come out doesn't mean that we should just abandon our good old CSF analysis that we do glucose and all that, because there has been documentations of false positive syndromic tests. So when you do the syndromic test, it affords you the opportunity of making early diagnosis and starting treatment immediately, while you go on with these other parameters. So when the other parameters come out, you compare it with your syndromic test result and know whether to go on or to temporize. Neuroimaging. is when you're suspecting the imaging stuff.
So like, yeah, now in a normal CT, you'll be able to see the brain, but it's not completely, you can't. Yes, so I ventriculitis.
So cannot reduction.
Yes.
There's so much is ventricle.
Yeah, so you can also have also the neural imaging are also
the midline shift if there's space of fine lesion like cerebral abscess, ocular abscess, subarachnoid abscess as complications of meningitis. You can have a push, just nature abhors the vacuum. Once something is occupying the space that the parenchyma should occupy, there will be it will give way. So
all right,
so this another meat of the discussion. So like in our index, it can be difficult to even identify cases of meningitis. Let's say the child had been to other facilities where probably nobody took time to try to elicit these meningeal signs. Nobody bothered to do a CSF analysis. And in such scenario, it might be difficult for you to even identify that the child in question has meningitis. So because it's when you suspect meningitis that you treat for it.
Yes.
So if you're not suspecting meningitis, you might just treat for malaria or for any other acute illness. Yes. So for those that presented to facilities that don't have the wherewithal to manage such cases, early referral might be necessary because the more you keep these children delaying their treatment, the more likely those morbidities and mortality might now eventuate. So early referral for us, the healthcare practitioners, is important. If you know you cannot manage case of meningitis, it's better to just refer. But I was taught back in school that how you know a good doctor
is the doctor that knows when to do.
Yes, once you know your limitation, you're very good.
Yes.
Not doctor that can handle everything. So health seeking behavior is also important for the caregiver to know that this child is not somebody to go to a pharmaceutical shop and get malaria. You give the first anti-malaria, fever is still there. You get another different brand of anti-malaria, complete that one, and call your doctor friend. Please, is there another newer anti-malaria that I can give my child? So those delays doing malaria treatment and all that might actually lead to some complications that are avoidable. So
solution of the, especially like 10 to 30. So if you are being diagnosis, you might actually morbidity. Sometimes when we say okay, it depends on treatment. Like if you're thinking okay, if you're thinking is if you're thinking it's strength, isolate anyhow
by faith complete, because one thing with meningitis worrisome as they come to you with cerebral palsy. The parents are tearing and you see a child that's maybe the only child of the parents, they've put in a lot to ensure that this child becomes very responsible and independent, but ends up being dependent because child cannot ambulate, child cannot feed him. Can be quite worrisome. So we should be intentional about isolating the positive pathogen. If your lab is not able to do that, that can help you, isolate these germs. Now, the other thing is, we had mentioned in the course of the presentation that when the meningitis is subacute or chronic, because those signs you're looking for won't be there. Yes. A child that had that the organism may be susceptible to, but is taking these drugs at the have those signs, and the parents may not bother. The child will be on and off, yes. Fever coming on and off, subacute. Acute bacterial meningitis within the first few days to up to 4 weeks is subacute. Is chronic. So when you have a child that your facility febrile illness that is not going, has completed courses of try and rule out subacute meningitis. So limit the morbidity and mortality that might result.
Okay. So we've come to another important part of
the second answer. So before the entries from people, okay, I think so we've okay, so basic principles of management. Rapid transport to emergency department is very important. A child that has acute bacterial meningitis that is not, especially meningococal meningitis. So there should be, and you don't just move them like normal movements from where things were. There should be an emergency transport, system where anybody that is very ill is picked up from his or her home, or any facility that has such a bad case or a critically ill child that needs expert care. So there should be an arrangement where an equipped ambulance service carries this child from the point of care, as in where the child is being taken care of, to, so that in the course of stative measures can be cleared, the child supplemental oxygen in transit, so that by the time facility or ensured.
So, like we mentioned, within the first because you can't discussing it because we have some antibiotics against this positive organisms. Like you give it adrenaline
common bacterial meningitis in this meningitis that will cause meningococcal meningitis, strep pneumonia that caused pneumococcal meningitis like in our index, and thirdly, ceftriaxone is effective against this thing. So if you don't know which medication to start on ceftriaxone, and let the ceftriaxone be as branded as possible, because some of the other generics may not have up to 1 gram of ceftriaxone in the vial. And the dose you're giving is meningitic dose, 100 milligram per kg per day. So once you do that and give concomitant steroids, dexamethasone doses can be anti-inflammatory or decongestant dose. Anti-inflammatory dose, anything you're giving that is less than 0.5 milligram per kg per day, less than that is anti-inflammatory. is the congestion edema, apart from um, dexamethasone, can equally in the brain. So before or with the first dose of antibiotics. Reason being that if the blood-brain barrier is porous, anything that wants to enter enters. You need to stabilize it so that your drug can enter and do the work. So if it's porous, anything can enter, and it's just like when you're pursuing a small child, you're trying to catch the child. You're coming from here, the child is entering from the other side.
Yes.
You may not be able to pin down whatever that is happening. And the more those pro-inflammatory events continue, the child will have a lot of neurologic sequelae, like all those motor deficits, cognitive impairments, convulsions, the seizures, even after the meningitis now, hearing deficit, cortical blindness, and the rest of them. So you don't want, after treating a child comes down with all those things. So that's why you need to do that.
So we've talked about already identification
of the positive pattern. So you need to isolate the germ that is causing it. Even if you are not able to isolate the germ now for maybe obvious reasons, maybe you don't have good laboratory support, you should, by way of getting a detailed history, know the focus of the infection. Meningitis is usually preceded by prodrome of upper respiratory tract, GI, that's digestive tract infection, urogenital infection, or skin infection. So if you're able to get the focus of this infection from the history, you will know the likely organism. Something in the throat, like this child we presented now, had pharyngitis, and the isolate was strep. Simple story. So if the child was passing those two before the onset of the meningitis, you also know some of those coliforms may be implicated. So those whatever you're giving needs to cover for coliforms. Then if a child had urinary tract infection, or maybe has a catheter that has been there for a long time, you know that the infection most likely came from the urogenital tract, and you know the germs likely to cause the infection, and you know what to give. So then the other thing is meticulous parenteral fluid. There's a way you give, the kind of fluid you give is important. There are some fluid that can cause cerebral edema on their own. If you give hypotonic fluid, like pediatric saline, so a lot of us are still doing pediatric saline. A child that is more than 2 months old, you're still doing pediatric saline. The pediatric saline in a child that is more than two months old will be hypotonic, and a fluid that is hypotonic will cause cerebral edema. So a child that has meningitis at risk of cerebral edema from all those vasogenic and cytotoxic events happening in the brain, you're doing hypotonic fluid that will now cause cerebral edema. Then you're treating, the child's conscious level is going down, and you feel like, what is happening? So you have to be meticulous about the parenteral fluid you're giving, and monitor the child for possible syndrome of inappropriate AGS secretion. You monitor the SCCR. One of the things that will tell you that something like that is happening is sodium, low sodium level.
So when that is happening, the fluid regimen will also change.
Yes, so by the time that happens, some people will not even, if you are not able to monitor, some people will just safely say, okay, let me just give 75% of maintenance, so that, because what you do for SIADH is just to monitor, as in reduce fluid restriction. So some people just play safe, give 2/3 maintenance or 75% maintenance, so that if they don't have the wherewithal to monitor, they just know that they are safe. Then flexible monitoring of vital signs, including level of sensorium, oxygen saturation, is important, because those are the things that will tell you if something is going on. Like if you do blood pressure check and the blood pressure is high, the pulse is low, you know that most likely there's raised ICP. So at the point you note that deranged blood pressure and heart rate, at that point you can start treating for raised ICP by raising the head of the bed by 30 degrees, hyperventilation, fusimide, the other, yes, we can also give monitor. So those measures that will help to reduce the fluid in the brain at that point can be employed. Once you notice that subtle changes in the patterns, then glycemic control is important. Hypoglycemia can cause its own problem. Now, a child with meningitis that probably is not taking enough calories, that now has hypoglycemia on top. You're just adding more, yeah. So that might affect the outcome eventually.
Supportive care, especially for a child that might be having a seizure, very important. That's just
seizure control.
Yes.
Because the more the seizures, the more edema that will happen, the more bad the outcome might be. So you want to control the seizure. You want to ensure that the child's airway is perfect. If there are secretions, to clear the secretion, because if the child is not getting enough air and saturation is poor, hypoxia can cause seizure. So by the end of the day, even hypoxia can also cause some cerebral ischemia that will eventually cause more problem for the child even after recovery. Then if there are complications, like electoral derangements, like we saw in the child, part of what we did that really helped the child recover quickly was the electrolytes, the management of electrolyte derangement. The child had low sodium level, had high potassium, had deranged blood urea nitrogen. So the way we were able to manage all those complications help the child recover. First, if there's a cerebral abscess, the neurosurgeon has to be, because pulse in any part of the body, management is to bring out the pulse. So if there's a cerebral abscess, the neurosurgeon needs to do bubble and bring it out. If there are arrhythmias, you have to give anti-arrhythmic drugs, amiodarone, and the other anti-arrhythmic agents that you have available.
So complications of meningitis can be early, which is something you can see during the course of while the meningitis is ongoing. So this can present like raised intracerebral pressure, intracranial pressure, hydrocephalus, which can either be a communicating or a non-communicating, depending on what is happening. So there can be venous thrombosis, cerebral edema, and shock, which is most commonly seen in meningitis. So, but late complications are, as you're doing follow-up in the next 3-6 months, you're seeing that child has intellectual difficulties. The child has some deafness, CNS forces, child is presenting, but there is maybe paralysis of the one half of the face. You're seeing that the child is not able to, there is ptosis, all these things. So these are late complications that present after you've already finished your management and you're doing your follow-up.
And these complications can be avoided by early concomitant steroid administration. So most of these things, the inflammatory changes and all that happens in the brain is what will lead. Some cytokines are part of the things that will be released into the brain that will damage some vital nerves and all that. So if you're able to start steroid early, contain the pro-inflammatory cascade, then these complications may not happen.
Okay, so
These are some of the explanations of pictorial representation of some of the complications you can see. In the intracranial abscess can be in the parenchyma, the brain parenchyma. It can be subdural, it can be subarachnoid, it can be there could be ventriculomegaly, hydrocephalus, and all that. So, when you're suspecting things like this, you do imaging. Imaging studies will help you. MRI, CT, cranial CT will help you know if there are such collections or not.
So these are some of the differentials. So meningitis is not always bacterial. So we have can be viral or aseptic meningitis, fungal, tuberculous meningitis, even protozoa. Yes. So, but it can also be some of the differential. We saw a case in our hospital that had like encephalitis, but the presenting some of the features were meningitis features.
Yes, meningoencephalitis.
Yes, meningoencephalitis, yes. So traumatic brain injury, epilepsy, a child that is seizing. So because seizures can also be presentation of meningitis, so it's also part of some of the differential diagnosis. So meningitis is an illness that can be recovered, right? With early diagnosis,
yes,
prompt treatment, important concomitant use of steroids, very important. Even the complications can be avoided. However, in cases where there has been early referral has not been done, early diagnosis treatment, the child can die within the first few hours, within the first 24 hours if there is no treatment. So in conclusion, it's our presentation.
Okay, so I believe that having engaged actively in this discussion, you will agree with us that we need to heighten our clinical suspicion of bacterial meningitis. Now that people travel like the speed of light, today somebody sees you, next second person is in another place and all that. So early diagnosis and prompt empiric antibiotics. Now meningitis is not a student of antibiotics stewardship, because the more you try to safeguard antibiotics, you have a lot of cerebral palsy patients. So once the index of suspicion is heightened and you have clinical suspicion of meningitis, start empiric antibiotics. So once you do that and you obtain your CSF sample, when you get the preliminary results, you know whether to continue or whether to give for a short period and stop. So that will help, limit some of the complications and the morbidities and the mortalities that result from it. However, I think we need to do more educational campaigns, cancel our patients, like our index. We tried counseling, but still she wasn't forthcoming about giving consent for the procedure. But we should not relent. We should continue counseling when there is need to get this diagnostic, investigations done. Let's keep counseling them, keep educating them, so that the acceptance rate of the diagnostic procedures can be increased, and the children with this condition don't end up having some of the complications that we see them in child neurology clinic.
Okay, and it's also important to know you can take some antibiotics to actually safeguard. Like I recently traveled, and when we arrived, they actually gave us a dose of ciprofloxacin. So which is something you can take, just a single dose, to safeguard yourself and your family against meningitis or rifampicin. So it's also important to know as part of our counseling and education now.
If you're suspecting meningococcal meningitis, like in this index, before we were able to isolate the germ, we counseled the household members, those that had come in contact with the girl, to take either Cipro for adults, 500 milligram PD for 2 days is fine. Sorry, 500 milligram daily for 4 days, or 500 milligram PD for 2 days. Rifampicin 600 milligram daily, or 300 milligram PD. So any of those two short course can be protective against meningococcal meningitis when there is suspicion of contact with somebody with meningococcal infection. I don't know if we have
So we have more
comments.
Comments.
Okay, kindly share guidelines. Support the use of dexamethasone in management of meningitis.
Okay, so there is a question.
Okay. Okay, there are a lot of, okay, let me try to answer that. Now, there are a lot of people that, have documented some randomized control trial have been done with steroid. A group of, participants that had meningitis didn't receive steroid. Another group that had meningitis received steroid with antibiotics. Now, there were a statistically significant difference, of neurologic sequelae, in those that didn't get steroid, as compared to those that got steroid. So this is not, it's not something to, and a lot of literature over there, maybe a lot of literature in the Western countries where they don't have the body as much as we have. Now, if you read a publication on meningitis in the United States, because of the nature of organisms they have there, they are not within this meningitic belt that will have meningococcal infection like us. So their own, and they already have, 23 valent vaccine against meningococcal infection over there. So their incidence of, from what you even saw in the course of the presentation, their incidence of meningitis is way lower than our own. Their own is not even up to 10. Our own is as high as 30 something. So 100,000 population. So you will not, when it comes to the one that you help, I think you should be in a position to tell what really helps. And all the cases we've seen in our facility that we started steroids, on, none of them is in neuroclinic for follow-up. So those that come to neuroclinic for follow-up are those that were managed somewhere else, didn't get steroid or didn't even get optimal doses of antibiotics and all that. So I think that will, put that to rest. You can, if you reach out to any of us, who can give you some of the literature that supports the use of steroid in meningitis. So thank you, Chief. Is there really a benefit of osmotic diuretics in meningitis aside restoring the cerebral blood? Now, most times when we give osmotic diuretics, we give it to children that have classical signs of raised ICD, because we're interested in reducing the cerebral edema. But you have to be careful with osmotic diuretics, because if there is bleeding in the brain and you give, a mass effect can cause more problem. So a child that has meningitis, nothing stops the child from having other complications, including DIC, which can cause bleeding in the brain. You go and give mannitol to such a child, the child will get to the other side faster. So it's not everybody that presents with meningitis that will give osmotic diuretics. We are very careful about those that we give and those that we don't give. What is the prognosis of Agrobacterial meningitis? Preterm lobe with. We know that preterm lobe with their problems are plenty already. So you wouldn't want them to have another comorbid situation like this Agrobacterial meningitis, which may not be able. Prematurity can cause CP. Meningitis can cause CP. You now have two comorbid conditions in. So as much as possible, all the infection control measures that can help them prevent additional infection should be employed, so that we don't even have that.
So the next question is
what is the role of
like
we've mentioned it now. That's a pro and a marker of acute infection.
But it's not specific to
So it's not as specific as you doing PCR for a particular pathogen. The your ability to isolate the germ is more important than you showing that there is an inflammation, which can be from any other thing. There are a lot of differentials of meningitis that will also have positive flow paracetamol and
The next person said, thank you for the insightful presentation. Kindly repeat the reason you give steroid just before commencement of antibiotics.
Okay, so the blood-brain barrier now is like a gate that helps control what goes in and what comes out. Now, in meningitis, because there's inflammation of the meninges, those pro-inflammatory events now make the gates porous. Just like if you have a house that there is no security guard, things can enter and go out. You rarely see some less than 5, as in more than 5 white blood cells in the CSF. You shouldn't even see bacteria in the CSF. So by the time there is express entry, so the bacteria will enter there and multiply. Because there are no white blood cells like in the bloodstream that can fight those rapidly multiplying bacteria. Once they are in the CSF, it's free for all. Before you know what is happening, they've taken over the whole place. So when you give steroid, it stabilizes the membrane so that you'll now give your drug will enter and contain whatever that is happening. As the drug is working, a pro-inflammatory cascade that tries to fight the germ, ineffectively, that will even lead to damage of essential tissues, doesn't happen. So that's one of that's the reason. And those that got the steroid, like when H. influenza type B was very, very rampant, those that get steroid don't end up having hearing deficit. So that can be found in some literature which we can share when
That's our last
you reach out.
question.
Okay. So thank you for joining us. We expect that same time next month when we come with another interesting presentation. Okay, thank you for your presentation. I don't know if you have experienced patients presenting with severe malaria, cerebral paracetamol, and suspected meningitis. Okay, approach. Okay, so now nothing stops a child with meningitis. Now it has been documented that some children with severe malaria, cerebral malaria is one of the manifestations of severe malaria. Nothing stops a child with severe malaria from having infection. It's been documented. For example, once they are treating for severe malaria, they give antibiotics empirically because of this concomitant infection. Now, for those with cerebral malaria, now you wouldn't want to give steroids because steroids will cause more harm than good. But not that children with cerebral malaria are having meningitis. God is not mean to carry two very life-threatening conditions and give one innocent child. So usually, if you're not able to diagnose cerebral malaria, and you now say you don't know whether it's cerebral malaria, you don't know whether it's meningitis, you now treat both of them, you end up causing problems for that child. Now remember, cerebral malaria, part of the diagnostic parameters is that you have ruled out causes of acute encephalopathy. You've done CSF analysis. CSF analysis doesn't point to meningitis. So if you're treating cerebral malaria, it's cerebral malaria. You're doing your artesunate or your quinine or any of the other parenteral anti-malaria that will sort out the cerebral malaria. Once you do that, after some time, the child will regain consciousness. But in meningitis, you're giving your antibiotics with your steroid. So there are two conditions that you really need to rule out what you're handling. You don't manage two of them because management modality for one is different from management modality for the other one. And most time when you do blood film for malaria, it's 1+. You don't say there is cerebral malaria.
The Limit Children Hospital is a multi-specialty children's hospital with advanced specialty in neonatology, pediatric cardiology, neurology, hematology, nephrology, and vaccination. We provide a variety of clinicians to help deliver the best possible care. Our physicians and nurses have been recognized by a number of independent organizations for overall excellence. We offer consulting services, regular nursery care, premature birth care, and treatment of babies with mild to severe illnesses across our different integrated facilities. Our neonatal intensive care units are well equipped with infant warmers, incubators, phototherapy, monitors, ventilators, and oxygen hood or nasal cannula. As a baby's and family's first pediatric caregiver, our neonatologists often begin their work by providing prenatal consultation to women experiencing preterm labor, carrying multiple babies, or following the finding of a possible congenital malformation that may require special preparation for the birth and coordination of treatment services for the infant. For more information, log on to www.limitchildren.org.